The recording will be posted on the committee's webpage shortly after the meeting. Pam McEwen, FTAC Liaison to the Universal Healthcare Commission, will now call the meeting to order.
Thank you, Mandy. Welcome, members. And it is now a couple minutes past 2 o'clock, and we'll call our meeting to order. I'm going to begin with a land acknowledgement. I'm coming today from the Methow Valley. And so I want to acknowledge that I am on land that was traditionally held by the Methow tribe, who have been stewards of this land from time immemorial. I want to give a warm welcome to everyone joining us today. I have in my notes that this is the 9th FTAC meeting, which is hard to believe. And so thank you to this team for your long participation. I'm going to start with an overview of the agenda. As always, we begin with roll call. And as always, we want to have people have a chance to get to know each other a little bit better. So we will have an icebreaker question, which is we're going to ask you what you're most looking forward to this summer. We will vote on the meeting summary. And then, as always, we will have public comment. And then Liz Arjun will walk us through the work plan review and let us know commission updates from the last meeting. Last time we worked together, we spent a lot of time talking about costs and how to kind of get our arms around the whole benefit design question. That was also discussed at the last commission meeting. David Giuseppe has generously offered to walk us through a build-up model that he uses. And then in addition, we have actuarial expertise and sitting in on our meeting today from Milliman. And I'm going to ask them to weigh in after David presents, if they have any comments, any observations that they want to share with us. After that, we will have an opportunity to hear from the Healthcare Cost Transparency Board from Ross McCool. And this is a topic that has been of just real great interest to all of FTAC members. This has come up a few times, so I know people have been waiting for this opportunity to hear from the Cost Transparency Board. So we're all looking forward to that discussion. Thank you. And then Mandy, I think we're going right next to you to roll call. And I think you might be on mute.
Yeah. So sorry about that. I'm muted so I wouldn't make any background noise. Thank you, Pam. When your name is called, please let us know, what are you looking forward to most this summer? Pam, we'll begin with you.
Okay. I am most looking forward to swimming and being able to swim outdoors.
I love swimming too. Christine?
Here, and I'm looking forward to a trip to London.
Oh, that sounds amazing. David?
I'm here, looking forward to long weekends and campfires.
I love that smell. Eddie?
Present. I'm looking forward to summer trips. This one's going to be to Hawaii.
Oh, to Hawaii, huh? That's great. Esther? Esther? Ian?
I'm here, and I'm looking most forward to playing golf this summer.
Excellent. Kai? Kai? Robert Murray? Robert Murray? Roger Gantz?
I'm going to be kind of staying at home this time, or closer to home. We're going to be doing travel to Lake Chelan, and go up to Sahegan and do some hiking up through Sahegan.
That sounds nice. Well, thank you, everyone. I'll turn it back over to Pam.
Hi, thank you, Mandy. So please join me in turning to the second tab of your materials. And the recordings of the last meeting is posted on our webpage. As always, we will use the consensus process for a vote on approving the March meeting summary. Is there any discussion, any issues or comments anyone wants to raise?
Pam, this is Roger. I would like to raise a couple, if I might. I'll try to.
Okay.
Those. And they deal with the section around benefits and service discussion. I think it's on tab 2, page 3 and 4. And I guess I have a comment. There's a section that deals with discussion around, sort of the overlapping of benefits between Medicaid, PBB, and the exchange. And I'm not leaving aside long-term care and the Medicaid. So I guess I'm not fully in accordance with that. I would hope, and we'll talk about later, that our actuarial analysis will point to where there are, what conceivably material differences. So I guess that my point being is that area 3 is a little trouble because it may be misleading to the Universal Healthcare Commission, saying that these are all essentially the same. I believe that's not the case. And then the last piece would be the section says that FTAC agreed that the commission should consider the following for actuarial analysis, beginning with PEB, the exchange, and layer additional benefits to that model. I guess I know we had a discussion on models. I felt that we didn't reach a consensus, and I hopefully will have some time this afternoon to further discuss this matter.
Did you want to suggest language changes?
Well, I guess the one would be is that the discussion around benefits is continues to be under discussion by FTAC. But maybe instead of that, we reached a consensus.
Does it say that you reached a consensus, or is it just details, items that you discussed?
I don't. We had a discussion.
Okay.
Time kind of limited the our discussion, so I don't think we really put together said, here are options we may want to consider, yes, no, and that we've gone through a consensus process. So I don't think, in my view, we've arrived, we being FTAC, with a consensus as to what we would recommend for actuarial analysis.
So is there a line that you recommend changing there, Roger?
Yeah, I think it's the first. It says FTAC, the FTAC agreed that the commission should consider the following for an actuarial analysis, and it goes on from there.
Okay, so it sounds like you would like it to say FTAC considered the following for actuarial analysis.
Yeah, that would be all right.
Does that work? Okay.
Thank you.
Well, we can make that change.
Thank you.
And then there was a second comment about Medicaid.
Yeah, this is more of a technical one, but I think that in that paragraph that kind of does a brief discussion of the different benefit designs, it sort of alludes to the fact that PBB's benefit design was designed for a specific group. The exchange with another, and Medicaid, which I have a lot of knowledge around, was originally designed, for example, for mothers and children. And that's not be technical. That's not true. More to the point being is I don't think these benefit designs evolve necessarily saying we're going to target to a specific target population. So where I think
So you don't like the language where it says originally intended for mothers and children?
Well, that's correct. That's not the case. Just as an example, it came from families with dependent children, and for elderly and disabled persons. Those are what they call the categorically needy programs, and that's the origins of the Medicaid program. I know.
Would you like it to add elderly, or would you just like it to end with period after Medicaid?
That would be my recommendation. Is that okay, Roger?
Thank you.
Yeah, rather than say something that feels incorrect, let's just remain silent on there. That's that topic. Okay, with those changes, are there further comments? Any discussion of the proposal? I propose we accept the minutes with the changes suggested by Roger. All in favor, please say aye.
Aye.
Any
Aye.
opposed? I think they're approved. We'll next move on to public comment. And committee members can find public comment under tab 3. We allow individuals to sign up to provide public comment before the meeting, and we will start with those that have signed up to provide comments. When you're called upon, please state your name and affiliation, if any, before speaking. We will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. And Mandy, would you please start with the names of individuals who have signed up?
I have checked the email box and I cannot find anybody who signed up in advance of this meeting. We did receive several emails asking in some questions, but no one just specifically signed up to provide public comments. However, if I got that incorrectly, because I know that there was a transition between Angela and myself, please feel free to raise your hands now. And I show Raleigh Watts. Oh, did you put your hand down, Raleigh? Okay, I will go to Holt. Nope, it's back up. Hold on just 1 second and I'll promote you to panelist. And then following that, I show Hull Washington, no specific person identified. And I've promoted you both to panelists. And Raleigh, you can go ahead and speak. Raleigh, are you available?
Thank you for bearing with me while I forget to unmute myself.
I had my problem earlier today too.
I'm Raleigh Watts, and I just want to say thanks to Pam and the members of the FTAC for all of your work. I'm a volunteer with Hull Washington. The point I want to make is this: the FTAC and Commission's work plan that was included in a packet just for your last meeting a month or two ago stated there would be a decision by the Commission on benefits and services in June. A decision in June. But now, today, in the packet before us on pages 24, 25, that work plan has just been extended. And in fact, there's no decision date listed for benefits and services that I saw on the updated work plan. I worry we're in a doom loop of not being able to decide about services without finances and not being able to decide about finances without services. I implore you to move ahead and make decisions so that we can continue this process. And in fact, in today's packet, Roger Gantz offers some really concrete options for not reinventing the wheel and how we think about benefits and services. Thank you, Roger. We have brilliant people in the room today. We can move forward and make decisions about benefits and services so that our timeline does not get bogged down. I represent citizens, activists, and consumers who are watching your work closely, who care about what you're doing, and who really need this work to continue with urgency. Keep the process moving forward. Our health depends on it. Thank you.
I showed Hull Washington, but I don't see them. And maybe that was Catherine Lewandowski because I do see you. Did you rename yourself? Okay, just checking. Go ahead, Catherine.
I'm gonna turn off my video because sometimes people can't hear me, okay?
Okay, sounds great.
Okay, yeah, sorry. And I thought I did send an email, but maybe I thought it was just one email to both the UHCC, I don't know. Anyway, okay, so thank you to the committee for allowing me to speak today. My name is Catherine Lewandowski, Vice Chair of Hull Washington, retired registered nurse. I apologize that I did not have time to review the materials for today, but I've been super busy since retiring, amazingly. But I wanted to stress today that we at Hull Washington are concerned, as with many others, about the level of wealth inequality in our country. And I see the funding of the trust as a good way to begin to neutralize that issue. So I do have a request for the committee. I'm curious about what to do about our funding plan as written in our last bill, Senate Bill 5335. In our last financial study, we did make changes to the plan by removing premiums as they were unnecessary. But although we could have also removed the capital gains tax, we did not feel that we should. Even though we saw that we did not really need the expected funds, we did feel that those affected by this tax should be participating in the funding of this plan to cover all residents of Washington state. And this is one of the few ways we can accommodate that. Currently, our language gives an exemption if anyone is paying other capital gains taxes on the same gains. We were under the impression that it would be considered a form of income tax and that we could only exempt $15,000. But the Supreme Court here in Washington clarified that it is not. So we'd like a little direction on what to do with that. Do we keep it as is? Do we increase the exemption? Do we remove the credit for any other capital gains taxes? Should we replace it with a wealth tax? We're interested in having a conversation about what would be best to do, regarding the funding of the trust to give it sustainability and make it truly a health trust funded by and for the benefit of all Washington residents. We welcome your input and thank you all for your time and efforts on this committee. Your work is valuable and necessary.
Thank you, Catherine. I don't see any other hands raised, but I'll just give it another minute if anybody would like to raise their hands. And that's all that I show. I'll turn it back over to you.
Okay, thank you. And thank you to those who commented today. We really appreciate this is your comments and your time you take to do this. It's a really important part of our work. I'd like to welcome Liz Argent, who's going to briefly walk through the commission's work plan, kind of to level set us all where we are and what we've done, and then give us some updates on the last commission meeting. So go ahead, Liz.
Thanks, Pam. Hi, everybody. It's good to see you today. Happy spring here in the Northwest. Yay, sun's out. Just we can go to the next slide, please. Really today, we have a few objectives. Number one, just want to provide some clarity and talk about where we're at in the process of the universal healthcare design. I know there's sometimes questions about where we're at in this thing. It's such a big process. We're going to deep dive into cost benefits and how that health plan would establish that. So it's an exercise for us to understand that, really prompted by the conversation at the last FTAC, where there were some questions about some of the assumptions and savings, to really just kind of try to take that apart a little bit. And then finally, we're going to discuss what actuarial analyses are necessary for the commission to identify next steps. Go to the next slide, please. So just to summarize where we're at in terms of the big picture, if we can go to the next slide. I think it's really important to always remember, the commission started out with 2 work streams, but now it's grown to 3. There are 2 tasks as part of the legislation were to design a universal healthcare system with a unified financing system. And the second task really is about recommending interim solutions that to address challenges that folks face now, but really kind of build the pathway towards the universal system that we're charged with designing. And then during 2023, there was another request from the legislature to review the whole Washington proposal. So we've added that on as a 3rd work stream. And hopefully this slide provides some background about where we're at and with each of those tasks. And I don't really need to go through all of them, but just to kind of say that for this 2024 year, we really are focused on determining the potential costs of the unified system, the universal healthcare system, based on the benefits and services decisions made about that, cost containment and provider reimbursement. And all of that will provide the basis for the actuarial work that's going to be ongoing. Under consideration in the 2nd work stream is really looking at administrative simplification, and then later this year, maximizing coverage in existing programs. And that includes PEB/SEB, that includes Medicaid, it includes Medicare. So many of the conversations that we had last year. So we're doing that as well at the commission. And that is coming here a little bit to the FTAC, but not as much as the 1st work stream. And then finally, with the 3rd work stream of looking at the whole Washington proposal, we're doing that in tandem as we do this work. And last time we looked at cost at the benefits and services and the assumed costs based on a request from the commission. So that's really where we've been. We can go to the next slide. And I just want to sort of recap quickly the decisions that have been made. So for now, just to summarize, because of the FTAC's recommendations, the commission has decided that the uniform financing system should be designed to include those with coverage under Medicaid, at the exchange, PEB and SEB, Public Employees and School Employee Benefit Board, fully insured employers and uninsured. And after much discussion and presentations last year, decided that we would continue to explore the possibilities for those with self-insured plans and for Medicare, but that at this point in time, there was no pathway to put those folks into the universal system right now. We've also requested an actuarial analysis of the cost of providing the benefits that PEB and SEB and Medicaid provide to enrollees in the system. And we will be requesting an analysis of the cost of eliminating or reducing enrollees' out-of-pocket costs. So these are some of the decisions that have been made. And this last one is determining, it shouldn't say determined, it should say that we're currently determining whether or not the cost of care is essential if the vision of a universal healthcare financing system is to be achieved. So we can go to the next slide. And so just to kind of remind everyone again of kind of where we're at again in the process, we've been focused in phase 1 over here. And over the course of the last year and a half. And if we go to the next slide, I apologize. I know I'm quite a visual person, so I need pictures. So I'm sorry if this is too much for folks, but really the way that we're looking at going through phase 1 is determining the eligibility, which is what we did last year. Now we're focused on benefits and services and going to cost containment, and then provider reimbursement and participation, which will give us a sense of how much this whole system would cost. And then we'll move to figuring out how to finance it. And the whole Washington proposal offers one of the potential options that we would consider in that conversation. All right, next slide. So just to sort of recap for 2024, our work plan calls for a number of key decisions. One, again, in the first work stream, focusing on decisions about benefits and services, provider reimbursement and cost containment. And then for 2024, in terms of the transitional solutions, our hope is to have some recommendations or key decisions around administrative simplification and maximizing enrollment in the existing programs. So that's what we're looking forward to doing this year. Any questions about that? I just kind of clipped through that really quick. Okay. Pam or David, I can give this update, but I don't know if you want to chime in here at all.
Why don't you start, and then I think
Okay.
David may chime in since he was at the meeting.
Sure. So just to provide all of you, if you were not at the commission meeting in April, there were several legislative updates that were offered, which are, I think are very exciting for the FTAC to hear about and for the commission to hear about. HCA staff provided an update on describing additional funding that is now available for the expanded Medicaid for folks who aren't able to access it because of their citizenship status. And that is beginning in July this year. So essentially at this point, there is now a pathway to coverage for all Washingtonians. There are still issues with access and affordability, but by creating that new program, which will launch in July, there is a pathway to coverage for all residents of the state at this point. And the exchange launched the program in January that has the subsidized coverage for individuals with a little bit of a higher income who used to not be eligible because of their citizenship status. There was another gap closed with the ground ambulance billing bill, and Jane Beyer from OIC talked about that. But I mean, I think the main takeaway that folks have is that there's a nice infrastructure right now for providing pathways to coverage and investments that have been made to make sure that folks are able to get healthcare coverage and get their needs met. We also talked about the approach to determining costs for the universal design, and talked a little bit about the conversation that FTAC had at the March meeting about benefits and services. The commission decided after hearing about the conversation that FTAC had that they would like to see an analysis of the PEB and SEB programs, begin with a silver plan on the exchange and the additional Medicaid benefits, dental and long-term services. So in terms of moving something forward for the first phase of an actuarial analysis, those are the three things that they would like to have the actuaries pull together. The other piece of the conversation that happened during the April meeting that was pretty important, Chair Lowe was very vocal about this, was that there should be, there was a, excuse me, we can go back. There was a discussion about the role of cost sharing. Chair Lowe was very clear that she did not think that there should be cost sharing, but there were other commission members that felt that we needed to model different cost sharing options. So the sort of settled agreement at the meeting in April was that we would focus on the first phase, which is just comparing benefits and services, and then move on to talking about cost sharing. And there was also a very extensive presentation on administrative simplification. So I'm not sure, we don't really need to go through these slides because we already covered kind of what we're doing in 2024. But if you want to go back, I just want to pause for a moment and ask David if there's anything you want to add from that meeting, or any of the FTAC members if you happen to participate. Roger, I don't know if you were there, or have any questions about their conversation.
I don't have anything to add, Liz. I thought you did a nice job of summarizing.
Thanks, David.
So Liz, this is Roger.
Yeah.
Sure, and unfortunately, I wasn't able to attend that meeting, or it wasn't online yet. So let me be sure I understand something. And this is the issue about benefits and services.
Mhm.
So is this correct that the commission has made a decision already on the actuarial analysis it wants to begin with?
Yes. It would like to understand how much the cost is to provide the public employee uniform medical plan.
Right.
Would like to know the cost of what it would be to provide an exchange silver plan. And then it would like to know the cost of what it would be to provide the additional Medicaid benefits. Those are for the first part.
Well, is this the time to have a discussion on this, or should we wait till later?
I'm going to suggest,
Wait.
please push back if you want, or anyone, but I think the discussion might be well served by hearing David's presentation. So I think we should, that's my gut, is to go there first, since he kind of is going to pick up kind of where Liz left off. Any concerns with that? Okay, well, hold me to it, Roger.
That is, I mean, and I guess I should say that really more than anything, they were very clear that these are the things they wanted to start with. That was the only thing. They knew that they needed more information from FTAC, particularly on this issue that we're going to talk about today, for later phases of the work. But they wanted to understand kind of really what are the differences between the core benefit packages that are kind of on the table with who's left in the big pool. So.
And, if there are things, as we get through the discussions that we have today, if there are things we feel like we would like them to consider or give them feedback, I think that's, I think the door's open for that kind of back and forth.
Thank you.
That's right.
Okay.
All right. I'm going to hand it over to you, Pam, and we can go ahead to the next few slides. Just go through them. That's fine. We don't have to, we've already covered all this. Okay. We're on tab 5, obviously. Thank you, Liz, and thank you, Roger, for those comments. So I'm just going to try to do a little bit of a segue to this next presentation. I would like to remind people of the fabulous discussion we had at our last FTAC meeting. It was really excellent, and much of it was in response to the presentation we had from Whole Washington, and kind of dealing with understanding the costs and total cost of care. In the back and forth with the commission, it seems like the kind of getting our arms around the total cost of care and the population that we're talking about is kind of our next task. And David DiGiuseppe has volunteered to show us buildup, kind of based upon the work he's used to doing with the population that he serves through his health plan, but also kind of expanding that approach to looking at who is included under the universal coverage plan that we're currently talking about with the commission. So I think that it would be best just to turn it over to David right now. And David, feel free to provide any context or any kind of a link towards the various things we're discussing today. And then at the end of the presentation, I will ask for our guests from Milliman if they would like to make a few comments, and then we can kind of launch into some discussion kind of along the lines that Roger raised. So David, you ready to go?
I'm ready, Pam.
Thank you.
All right, thank you for that. Yeah, I would like to give you context in terms of 3 different perspectives that I hold as an individual, as a member of FTAC, and then as an executive at a health plan. You know, on the individual side, I share some of the same concerns and sense of urgency that we hear from our colleagues at Whole Washington and other advocates who have taken the time and energy to make their public comments. And that's what makes me excited to be a member of FTAC along with all of you. I think as healthcare and finance professionals, we're in a unique position to objectively look at what the commission is trying to understand and come up with the best ways to articulate for them what the breakthrough opportunities might be as barriers to regulatory issues of financing and so forth come up. I do, on the professional side, I am employed by Community Health Plan of Washington, which is a health plan in the state of Washington. Our largest book of business is Medicaid managed care. We also have Medicare Advantage plan and a Cascade Select public option plan. I'm the Vice President of Healthcare Economics. I lead an actuarial team, but I am not an actuary. In fact, I ran this presentation by the Director of Actuarial Services on my team, and she referred to it as primitive. So Ben, if you are going to corroborate that, I'm prepared for that. But I think what she meant by that is when an actuary gets involved and looks at some of these issues, they're much more, there are many more considerations, and the analysis is more complex than I've made it here. What I intend to show you is the general way that a health plan looks at pricing a product. And that touches on several of the issues that have been raised here at FTAC. And what I transition into toward the end is how I think about the work that we're doing. I've been trying to get my head around what have we accomplished in relation to what the commission has asked us to do, and how might we help the commission even more, and in terms of how we prepare and frame up the actuarial analysis. So this may be an oversimplification for many of you. Some of you might find it valuable. I think the question on the table isn't so much, do you agree with my analysis, but does the way I have presented this spark ideas in your mind so collectively we can come up with a method not only for directing the actuarial study, but for characterizing the results in a way for the commission that illustrates some of the points that we've been raising here, especially folding cost into the conversation. So about 25 slides. I don't really get to the cost issue toward the end, and I'm trying to fold in the things that I've heard that Bob and others have expressed. Okay, so this first part is how a health plan approaches pricing a product. So if you don't mind going to the next slide. So the first thing we do is we identify the base experience. So we need a body of utilization and expense data from which to project forward. So we identify the population that we're talking about. We assemble the claims history associated with that population. Claims come from hospitals, specialists, etc. There may be non-claims costs that need to be built in, like quality incentives that are paid to providers. And that base experience represents the services that are covered, which is one component of the benefits, as we talked about at our previous meeting. It implicitly assumes that there's a utilization rate tied to those services, and then it's priced out at the cost per unit of service, which we start with what we call the allowed amount. So that is what we're willing to pay the provider before we take into account member cost sharing. Next slide, please. So once we have that base experience, then we need to project forward. So one of the things we think about is that population going to change? So we identified the population in the base period. Is that population going to grow? Are we going to attract new members into that population? Is the population changing by definition? We consider from the consumer or the individual standpoint, the things that they make decisions on. So they're looking at their insurance options and they're thinking about the price, the network and access to providers that they have, the benefits that are covered, and any service issues in terms of ease of working with the insuring entity. And then there are market dynamics that might change some of the decision making. So if premium subsidies are available and make premiums more affordable, that could drive changes in the population. We also have to project the healthcare expense. So we look at, are the services to be covered in the future the same as the services that were covered in the baseline, or are there some services being eliminated or added? Are there any changes in the utilization rates? For example, is the health status of new members going to be similar to the health status of existing members? Might there be some bias in terms of how the network is designed, or how the cost sharing is set, or the plans that are available to people that cause selection in who's signing up for coverage? And then there's the cost per unit of service trend. So there's just general inflation, but there are also contract negotiations where a provider or a large hospital system, for example, may say, we want to restructure the way that the contract is designed. We want higher than inflation payments. We want value-based terms, et cetera. Next slide, please. Then we overlay the administrative expense. These are things that the insuring entity, so in my case, a health plan, activities. So we have to be prepared to process eligibility and enrollment files, contract with the network, depending upon the degree of management in the managed care side of things. There's utilization management or prior authorization. There's care management and population health, where we attempt to identify high-risk members and line them up with nurse care managers, community health workers, et cetera. And then there are sales and marketing, IT, et cetera. There's been some talk at FTAC about eliminating this administrative layer of expense. And there's probably some opportunity there under a single payer system, but even under a single payer system, a lot of these activities would probably come into play. Otherwise, you would have an open fee-for-service system, which tends to push cost up. Next slide, please. All right, after we've done that, we basically have a model of 100% of the cost, or the total cost of care for that population, ignoring who's paying for that cost. So what goes into the practical side of this and figuring out who's going to pay for it is how much cost sharing there would be. So just for sake of argument, let's say that 100% total cost of care is $1,000 per beneficiary per month, or per health plan member per month. Somebody has to pay that premium, whether it's the employer or Medicaid or CMS for Medicare Advantage, or the beneficiary themselves, the covered individual. Once you start overlaying cost sharing on that, the premium goes down, but the out-of-pocket cost sharing at the point of service goes up. So for example, if we say we're going to have a $200 deductible for every outpatient surgery, which is just a hypothetical example, that $1,000 premium might come down to $800, but now every time somebody goes into surgery, they face a $200 deductible. Next slide, please. And of course, there's a feedback loop, as you modify your cost sharing, that's going to impact your utilization assumptions. And so you're going back and forth between these things. If you implement any member incentive programs, you might increase your administrative expense, but lower your healthcare expense. And so there's a lot of work that's, as I said, much more sophisticated than what I'm describing here. Next slide, please. So what is the relevance of this to the discussions that we have? We've talked about how our current system is fragmented. I think we know the total cost of care. I think if we look back at the Universal Healthcare Work Group reports, if we look at the work that Whole Washington has done, there are estimates out there of the total cost of care for the entire system. As I mentioned in the beginning, I've been trying to figure out a way to pull all this together and visualize and even present to the commission how this all works in tandem and what part of the system is being operated on when we talk about benefits or when we talk about cost sharing or when we talk about hospital budgeting. And so whenever you see orange on here, that's using the next few diagrams to show what part of the system are we operating on. Next slide, please. One simple way to visualize what I was saying before about the trade-off between member premium expense and member out-of-pocket cost sharing at the point of service is just to go onto the exchange and look at rates that are already out there and published. So I went to Health Plan Finder, put in 98101 as a zip code. Male, age 40, non-smoker is the index rate that we all use when we file our Cascade Select filings. I happen to pull up coordinated care. I should say, I purposely didn't put this presentation on CHPW letterhead PowerPoint because I'm presenting these views as my own individual views as a member of FTAC and not a representation of CHPW's views. So you can see that if a member chooses a bronze plan, which has a 60% actuarial value, and what that means is the plan covers 60% of the total cost of care. The premium's $292 with significant out-of-pocket costs with a deductible and copays. If that individual were to select a silver plan at 70% actuarial value, the premium goes up substantially while their cost sharing goes down. So a fairly simple example, but I think as I was listening, sitting in for Pam and reporting to the commission about our conversations at the last FTAC meeting, one of the things that struck me is there is an opportunity, I think, for us to illustrate to the commission these various dynamics. And I think in some cases, the information is out there and doesn't necessarily require an actuarial study. And in other cases, I think, new actuarial thinking and analysis can bring some new information to the table. And I think it behooves us to think about the best balance between those things. Next slide, please. All right, so this is the conceptual framework. This is basically framework that is basically a look inside my mind and how, as we're talking about these things, I'm trying to organize and relate these different issues to one another and essentially put them in a unified model. And I'll say I started with Excel and it was no fun to look at. This is a little more fun to look at, but it's pretty simple. It may not resonate with the rest of you, but I thought we could try it. I didn't have time to go back to the reports that have been written previously and pull in actual dollar amounts that I think probably exist. So I was putting an arbitrary hypothetical dollar amount. So please don't get attached to any of the numbers in here. Next slide, please. So what I attempted to do was for each of the markets that we've talked about or plan to talk about to represent the total cost of care in the rectangle that combines all three colors you see. So that's a depiction, an illustration of the self-funded market, which relates to the ERISA conversation that we had. And that cost is based on the amount of services used times the unit cost for service. And I purposely depicted it that way because theoretically we can operate it on both of those axes and attempt to modify the utilization rate, attempt to modify the cost of service, and change the height or width of that rectangle where the whole volume represents the total cost of care. I also attempted to show that within the rectangle, a big chunk of that is paid by a payer. So in self-funded, it's paid by the employer. A smaller chunk is paid by the individual in the form of premium and out-of-pocket point of service costs. And there's an admin component that is built into both the payer funded side and the individual funded side. Next slide, please. So, theoretically, we could do that with all of the different markets that we've been talking about. Next slide, please. What I'm showing here is my reading of the work group's Model A looks like this, where Model A attempts to squash all the markets into one and bring the total cost of care on the commercial side down toward the Medicare level, bring the Medicaid unit, sorry, I said total cost of care, the unit cost in commercial down to the Medicare level, bring the unit cost in Medicaid up toward the Medicare level. So there's a single fee schedule that's applied. And as I recall, what the work group postulated is that in redesigning the system this way, there'd be $8 billion of savings across the entire system. Next slide, please. Going back to that individual market, or sorry, the separated market model, we've already talked about the barriers to folding a self-funded system into a unified system. We've talked about the barriers for Medicare. So what we're really talking about right now is what can be done on the large group, small group, and individual, commercial market, and on the Medicaid side. Next slide, please. So one of the things that the commission talked about that I think Liz summarized is a desire for us to look at eliminating cost sharing from the system. So all I did here was highlight what used to be green and orange and say, all right, if as a system we're going to eliminate cost sharing, I think we have to be clear, are we talking eliminating premium and out-of-pocket costs, or are we just talking about eliminating out-of-pocket costs? What would that cost be? And so I think with a model like this and the numbers that are out there, we know, or we have a good guess as to how much it would cost the system to eliminate cost sharing today without redesigning benefits and studying what the benefits would cost. Next slide, please. I think we've also have this question on the table of bringing folks who currently aren't insured into the system. We talked about how the legislature has done that through the new Apple Health expansion that takes effect July 1st. That is capped. So I think statewide, maybe 13,000 people are anticipated or allowed to enroll in that program with current funding. But I think with information that's out there today, or with help from actuarial folks, we could cost out what would it cost the system overall to get to 100% coverage, put it by covering anyone who's currently uninsured in Medicaid. And similarly, we could do that with any other line of business. Next slide, please. Let's see, what was that showing here? Oh, so there has been the question on the table of covering additional services that aren't covered by various markets today. And I think that's the conversation we had recently about lining up the different markets, identifying which services aren't covered, what's the total scope of services we want to cover. And to the extent any market isn't covering those services, an actuarial group can help us price those out. And I think that those would be relatively low costs compared to the other slides and expansion issues we've been talking about. Next slide, please. So I think there's a way to illustrate for the commission the different dynamics they're wrestling with and what an estimated cost would be for each of these components, which I think begs the question that we've been talking about here, which is, okay, if we're going to expand services, expand coverage, et cetera, should we also be thinking about reducing the overall cost of the system to make it more affordable? Next slide, please. And next slide. So, again, I think we've talked about this in two ways. At the bottom, we've talked about the feasibility of eliminating some or all of that administrative expense. That top orange dashed box gets at some of the points that I think Bob eloquently has described around, can we reduce the unit cost through things like hospital budgeting, spending, target caps, things like that. Next slide, please. The potential cost reduction opportunities, there's already been significant work outlining these. We've talked about global budgets. The Transparency Board, I think, has published spending targets. The state has talked about spending caps. I think we had a presentation on spending caps from folks in the Northeast. The OIC and HMA have a report that came out recently that outlines several policy options along these lines. And the Attorney General recently released a report talking about private equity consolidation and the effect that that's having on pushing costs up. And I think we've seen in our neighboring state in Oregon, there have been some legislative or regulatory actions preventing some of that consolidation. Again, we can also look at the admin side of things. I think that's a valid question. I personally believe that a lot of those activities need to happen in one form or another, whether we have a single payer system, a social insurance system like we talked about last time, or the existing system unchanged. Next slide, please. So I think this really just gets to teeing us up to have the conversation, hearing from Pam and Liz about what the commission wants us to think about next. What I propose is that we have an opportunity to potentially interpret what the commission is asking us for in order to help them not only understand some of these issues, but the consequences and implications of an actuarial study, in addition to designing and directing an actuarial study to fill the content of a report that would go to the commission. See, I think that's my last slide.
Okay, I'm gonna thank you, David. That was great.
You're welcome.
I would first like to ask Ben Dietrich if he would like to make any comments.
Sure. I think the framework was pretty well put together, David. I don't have a lot of immediate questions. I guess the one piece that I struggled with a little bit was the $8 billion of savings that seemed to get lost as we moved into the consolidation. And I guess my biggest comment would to just try and comment about the accuracy of making these estimates. When you smush everything together, for example, not to pick on the slide, but the Medicaid expenditures, those didn't look like they were representative of the directed payments that are also included within that program. So getting everything added together and trying to understand what the total current spend is a pretty challenging ask to begin with. And then if we go to the Universal Healthcare Commission side, where we're now going to try and see what the impact is from combining it all together in whatever program we're looking to combine it all, then how those things are going to react is going to depend on what that system is that's going to get put together. So I think when you look at that and try and make then a prediction of how the market is going to react to that change in forces that are now impacting with them, I think to think that the providers are going to be able to accept less to do the same amount of work, if not a little bit more, if the benefit package changes, is going to be a tough ask. So I would just want to make sure that everyone's, thinking about how that savings is actually going to come out in the end just from changing the structure of the system. The other piece is just trying to understand who's involved in the medical management of them. So is that the carrier's role? Are carriers kind of I'm coming in cold to this FTAC. This is my first one attending. So it sounds like you guys have had a lot of conversations about what the structure is going to look like, but would there be any sort of third-party medical management, or is there going to be a third-party entity that's contracting with the providers so that we're kind of, keeping in line with, after we've combined everything all together, how are we setting that allowed price consistently across all markets? Those are just some initial things that I couldn't really pick up when I was reviewing the materials ahead. But it's definitely a lot of good information that you're going far so forward. Knowing that you've had these thoughts, David, it was right in line with where I was thinking the model was going to go. So good job there. I don't think it's very rough at all.
Thanks, Ben. That was a real nice way to say primitive. I appreciate that. I think your points are fantastic, and I might be able to help clarify a little bit, Pam, if you don't mind, or
yeah.
Okay. Mandy, do you mind going back to that $8 billion slide where everything gets squished together? It's up higher, where there's just one big rectangle that everything is combined.
Yeah.
So yeah, the one you're just telling me. There you go.
The mushed one.
Yeah. So Ben, I might be remembering this wrong, but I think when I read the Universal Healthcare Work Group report, which was, the work group was the predecessor body to the commission. In their report, they articulate this combined system and talk about, if you combine everything into one, you could expect billions of dollars in savings. And the vehicle, as far as I understood, the vehicle to get those savings was to bring the commercial fee schedule, and that overcompensated for bringing the Medicaid fee schedule up. But Mandy, if you don't mind going to the next slide. Here at FTAC, we've already told the commission that to create a unified system is infeasible because you'd have to have congressional action to take control of the self-funded market and the Medicare market. And so the point that I probably lost you on is that when we're talking now about affecting expense, we're largely talking about the remaining commercial market and the Medicaid market. So, should we add benefits to the large, small, and individual market? Can we do something that might bring the cost down, the unit cost down there? So I think ultimately the actuarial study is not going to be about that squashed together picture. It's going to be about this picture, and we're not anticipating any connection to that $8 billion.
Okay, good.
And this is Liz. I'll just say, since I was involved with the work group, those were very large. Those assumptions there were a lot. As somebody, one of the actuaries that worked on it, there's a lot of assumptions that it wasn't quite clear where things would be coming from. Anyway.
What was the time frame of that work group? When were they around?
It was during COVID. So it started in 2019, I believe, in the summer, and then went online in 2020, and then I think it ended in 2021, but I could be wrong. It was like 3 or 4 years ago.
Yeah, this is Roger. Ben, have you seen that report? I mean, we can send that to you just for background information if you haven't seen it.
No, I think he's.
Yeah.
Ben, did you have anything else you want to add?
No, I'm good.
Okay, I really appreciate the weighing in, especially on short notice. That was helpful. Christine's had her hand up for a bit, and I'm eager to hear what she has to say.
Yeah, so I was just wondering about the assumptions around, there was a slide that you showed about, eliminating cost sharing, and it looked like from the picture that like the assumption about cost was just that cost sharing would now shift to the state. But there's also potentially a demand effect there that would have to be considered. And similarly, even looking at this slide here, like thinking about the, it's a smaller piece of the pie because we don't have self-insured, but there could be shifting into self-insured. So I just wanted to ask, I guess, what the actual, are the actuarial assumptions taking this into account, and how much uncertainty does that introduce into any kind of analysis?
Yeah, that's a great point, Christine. I want to be clear, there are no actuarial assumptions in here. Like, this is just a conceptual approach. And where I mentioned above the interaction between cost sharing and selection, like, I think what you're pointing out is a great example of that, something that would have to be taken into account. And thankfully, someone like Ben gets to think about that, and I don't have to think too hard about that.
Mhm. It's a good point. It's a moving target. So you start to make changes, people will change their behavior. Other comments or questions?
This is Eddie. Great job, David, for putting something together that we can all look at and kind of pretend we understand. But I think it's almost like it's a group exercise where the X and Y axis is visible enough to kind of chat about and then play with, I guess, the volume in each one of these rectangles. And as we go through, I guess, our next, meetings, we figure out, okay, we're looking at this piece of this rectangle, and here's where we're going to focus our efforts on. So I think from that standpoint, your presentation was well received.
Oh, great. Thank you, Eddie.
Other comments or questions? Roger. I think you might be on mute.
This is time to introduce a previous discussion on benefits.
Yes.
So, Dave, by the way, a great presentation. Hoping it's understanding a complex matter. It's always been my view that we're trying to build a system. We got to start somewhere. We being the commission and ourselves, have sort of articulated at least a path with who could be eligible for this universal system in the near term. And this repeating what we said many times before. We suppose there's unique challenges that we just set aside for the time being, and we can't get there today with Medicaid. So we've said, I'm sorry, Medicare, beg your pardon, Medicare. So we've laid out that to the commission saying, well, let us try to design a system that includes everybody else. And just one sidebar, I can't help but keep advocating for this. The state itself, of all people who are insured in the state itself buys coverage for over 40% of the market. This is a reference point. That's PBB, SEB, the exchange, and Medicaid. So we're already, at least the state, having a major influence in the market. So I felt that one of the things that was, so we said to them, okay, so here's who's in and out as we see it near term. The next piece of the back is, well, what about benefit designs to model? And my own view is, I don't believe we reached, maybe I just didn't hear correctly, a complete set of recommendations back to the commission with respect to how you could do benefit design modeling. And I sent to folks a memo that tried to lay out sort of three things, sort of three-dimensional one, this with respect to benefits. One is, the benefits themselves, services, amount of scope and duration. There's a conversation that needs to occur, David, as you articulated, about cost sharing. Yes, no, and if yes, what? And then a conversation for certain later time is what is going to be the payment structure for this new system. And I believe, though we kind of dance around a little bit, there's an implicit consensus around, lack of better words, a uniform pricing structure. Leave aside what that is today, but that's a piece of it. So that said, is I felt for the commission, two things. Pam and I and others have been through a process in the past where we said, let's try to build something, from the beginning. And we did that in 1993. It was a long process. And I think at the end of that, there was some acknowledgement as we built something, but it's going to be an evolving model and we'll go forward with it. I think for the commission is to say, when you're looking at benefit options, we have some models today that would behoove us to actuarially model to see what those differences are and to provide, if you will, a menu for future modeling. And in that memo that I sent you, there were sort of five of those. Let me just try to go through this quickly again. One is there are the essential health benefits that are required under the ACA. It's kind of, if you will, an essential basic building block. Our state has gone ahead and added 14 additional benefits today that exist there. So Washington has an essential health benefit, the basics. If you look at the enabling legislation around essential benefits, which governs both the small group and individual markets, there are optional benefits that are outlined that the small group and individual market can offer. So it's an additional set. Great ones, usual ones, vision and dental are always good examples of that. So that's a second, if you will, constellation of recognized benefits. The third, and we've said time and again, is SEB-PEB, which essentially is the same benefit design. That's a third, if you will, benefit design to consider. That should be analyzed. The fourth one is Medicaid, and I always want to say to folks with respect to Medicaid, it's Medicaid absent long-term care. That is a world unto itself, and I'll talk a bit about how we can look at that at least. So the fourth of those would be, what is today Medicaid absent long-term care? The fifth that I felt we would, at least for the commission, would be informative is, what does Medicare look like? What, if I at least would envision that, you would say, here's what these actuarial equivalents look like. So when you're thinking about benefit designs, here are standing benefit designs that as you go forward, you can pick and choose or model all of those as you go forward with how to finance. And I guess I would like to bring back to the folks some consideration of offering those set of recommendations back to the commission.
Roger, and maybe Liz can help me out here too, is I think some of those have already been adopted by the commission.
Yeah, they've said EHB, they've said PEB-SEB, they've said Medicaid, they've said Medicaid. I think the Medicaid piece we should clarify because they wanted to know how much it would cost to add the additional Medicaid benefits.
Mm-hmm.
So the two versions of Medicaid, I guess. There's Medicaid like with long-term care, and then there's Medicaid absent long-term care.
Okay. Can I talk about that for just a moment?
Mm-hmm.
I can tell you that Milliman and others can model what the Medicaid benefit program looks like. If you look at medical, behavioral health, dental, the usual aspect of it.
Mm-hmm.
They can't model long-term care because they don't know what's there.
Mm-hmm.
Yeah,
I don't. It was absent long-term care. It was dental and vision.
Yeah.
Let me do something there for just a moment. There is a way to provide some useful information to the commission through some modeling efforts that research and data analysis over at ORDA can do over at DSHS. And what they can do on that long-term care side, and this is informative, I'm not going to bring that in. What does that look like? What is that array of benefits? How much are we expending there? What are costs per beneficiary? They have data to do that analysis from the Medicaid program. I mean, they do it now. And that would be a useful part not that it'll be part of a benefit design today, but just to remind folks, when we're talking about Medicaid, we're talking about this piece that's going to be in the system, and here's long-term care. What does that mean? Here's what it looks like, and here's some background on it for future reference. That
I think
done.
Go ahead. I'm sorry, Roger. I thought you were finished.
No, so.
I'm sorry, Roger, I did misspeak. It's Medicaid with dental and vision benefits. No long-term care. So EHB,
Yeah.
HEB-SEB, Medicaid absent long-term care, but yes, dental vision. And then Cascade Care was the other thing that we talked about
Yeah, but
at one point.
can I come back? Now be quiet. Pam, correct me, when I think of Cascade Care, I mean, the exchange is required in its base thing to provide the essential health benefits that are mandated by the Affordable Care Act, plus our state has added some other ones that are offered in the exchange, right?
Yeah.
And it's not, Cascade this or that. I mean, Cascade in one respect is a payment structure that sits on top of that, which is a key issue, but it's not a benefit design in and of themselves. So I just
Well, I
want
think
Cascade Care is benefit design, not Cascade Select the public option. I'm sorry, Pam, you were probably just about to say that.
that's all right, Manny, go for it.
what is additional?
I'm sorry?
In Cascade Care, what are the additional benefits?
It's specified. There's a whole list of benefits, like such as copay design, and caps to copays, certain things pre-deductible. So there is a benefit design to Cascade Select. It's what we call the standard plan. But the public option offers its model as the standard plan because it's part of the Cascade program. But the public option is distinctly different in that you're right, Roger, it is sort of a payments capping structure, but it utilizes the benefit design of what we call the Cascade Care program. And Pam, I will turn that over to you.
Well, I think several of us here know have lived a lot of Cascade Care development, but I would, it's Cascade Care has a specific design of co-payments, cost sharing that are designed to encourage early visits and preventive care visits. So to me, that is actually an essential way of thinking about a benefit design. And I think it should be of interest to the commission. I actually think, Roger, the thing that the commission is most hung up on right now is point of service cost sharing or premium sharing, because I think there's there's a belief, whether or not we should do something in which there's no cost sharing or whether not. And I think that actually will be an area where this team will need to weigh in on, and also be prepared to talk back. And I mean, they got wrong choice of words, but really to give feedback back to the commission related to cost control. And because if we start to develop a very rich benefit design with very low cost sharing across a population that isn't going to generate the revenue or the low medical costs that you would in a commercial population, the cost is going to blow up very quickly. And then we need to talk about cost control. So that's going to be another area to think about, Roger.
Right. Well, one more thing, I'll shut up. I personally strongly agree, but I guess my own mind, I say, here's the benefit designs, here are these models, right?
Mm-hmm.
And theoretically sitting in each of those benefit designs are a series of developing some cost sharing models. You're going to do a 5% or 10%, the usual drills we go through. And when you see that, for the work that Ben and others do, you can say, well, look what that's doing in terms of utilization, et cetera, to the costs that are going to be borne not by the individual, but by the state or, in a premium that somebody's got to pay. And you can see all that impact.
Mm-hmm.
I think when you look at a matrix like that, that helps, in my view, provide some more guidance and education to our friends in the commission that I think they desperately need.
Yeah. David, you had your hand up.
Yeah, Roger, I appreciate how thoughtful you are about these things. And I'm trying to imagine that matrix you just described filled in.
Mm-hmm.
And, because I think you started by saying we would make an assumption that the cost structure is uniform across those markets. And I'm guessing, I might be wrong, but I'm guessing 95% overlap in covered services between all of those markets. And there's a small percentage of things that might be covered in the essential health benefits that aren't covered in PEB and SEB, so on and so forth. And so if that matrix was filled in and it said, the PM cost, allowed cost before any cost sharing for PEB and SEB is $800 PM. Under essential health benefits, it's $815 PM, and under Medicaid, it's $820. And you multiply that through, and we see, okay, that's $500 million here and $400 billion there. What would the commission do with that information in relation to what Pam's talking about, like the magnitude of the cost sharing question?
Well, can I ask a question or just pose something to you? Because David, one thing that I'm trying to that has sort of dawned on me listening to your presentation, or not even dawned on me, but I think when you talk about the total cost of care, the exercise that you go through, I think basically, I think, Roger, to sort of wrap up, I think we're in agreement in the sense that, or at least I think you're saying the same thing that we are, like, start with costing out these 4 to 5 maybe benefit packages. The second piece of it would be figuring out the cost sharing. But I think what you put in your memo, Roger, and what I think David is kind of pointing out is that actually, before we go to cost sharing and even talking about that, it might be worthwhile to think about how we can reduce the total cost of care so that when we go think about how much we're going to charge people, it's less. I just don't know what order it happens in, I guess, is what I'm saying. Do we want to talk about cost sharing first, or do we want to talk about things that can be done to reduce the total cost of care?
Well, in my own view, I think we start with the basics and leave aside reducing costs from it. Believe me, I've been in a world that's had to deal with this. I'm not trying to set that aside. But you start with that basic structure, right? And you run these two big models and you say, well, if we eliminated, if we eliminated cost sharing and we brought in all publicly financed programs, that's going to cost X number of bucks, and if we incorporate various forms of cost sharing, service cost sharing, it's going to reduce the premium and costs, per member per month, and et cetera, the financing that the state is going to have to figure out how to come up with. But you model those things, right? In my mind, so you can get a feel for yes,
we might be saying the same thing, Roger.
Well, okay.
But I think that you are all saying the same thing. I agree. But what's your starting model? I think maybe there's a differentiation in how we're going about it.
I'll say one more time, but the starting model, in my humble opinion, would be here are the services, here are these 5 buckets of services. There's, you can go find out where they are. Ben and the actuaries can run all of it. They have all the data, they can run that. We could advise on a series of various, of cost sharing options. No cost sharing, the platinum plan, the gold plan, silver, whatever. I mean, those all exist today, right? Use that notion. And then here's another piece that you cost that with. That, it seems to me, gives you a basis in the start. In my mind, you need to start there. Then the next step, or steps thereafter, is to say, how are we going to reduce or mitigate the cost trends that are associated, with healthcare? And there's a variety of discussions that we and the health benefit, the healthcare cost containment board would need to engage in, and what are those strategies? But I see that as a separate piece that we do after we've kind of set a foundation.
And you think that, so Roger, I just want to make sure I understand, but you feel like having information and discussing cost sharing before talking about cost containment?
Yeah, sure.
Well, my question is that if you know, and I think you put it in your memo, I don't know if it was reference-based pricing or something like that, right? If
Yeah.
you intentionally design the system with that in it, it lowers the cost overall. So then when you get to the conversation about cost sharing, there's less cost sharing potentially required. Is that, I don't know, I'm not an actuary, so I don't know, but that's what I'm thinking about in my mind. And part of today's conversation, after this whole conversation, is really an opportunity for the rest of the FTAC to get, you know, become aware of the work that's going on around in that space in the state and how it can be incorporated into the design.
Yeah, I would actually like to invite, and I see David's hand, and maybe hear from Christine and Eddie and others, just others to weigh in on this, whether or not we are simultaneously include, you know, we're front loading the discussions of cost saving measures, which this group has talked about a lot, or taking a more linear approach. But David, go ahead.
Well, just having heard more of your explanation, Roger, Liz, I think it probably is possible to do it all in a combined analysis, and then it becomes a question of how do you present that information? Do you present the base first with cost reduction opportunities after, or do you talk about cost first? So, you know, just, I don't know how Ben feels about it, but I think in actuarial exercise, you have to assume some degree of pricing, and you can modulate that assumption in the pricing exercise, and you can get different scenarios. And so all of those pieces, the services can have different scenarios, the cost sharing can have different scenarios, the underlying unit costs can have different scenarios. It's a lot of work to organize it and figure out how to present it. But I'm coming back to feeling like we're probably all saying something similar. It's just either order of operations or order of presentation.
That's right. That's what I think you're right. It's the sequence.
Yeah. Liz, the other thing I would say is in this ideal world, the commission's going to want an interactive model. I can hear the dollars on all this going forward, but they're going to want to do at some points in time what ifs, right? I'll give a simple example.
Yes.
The Cascade uses 160% of Medicare as its index pricing. Is that right, Pam? The old task force said, well, we're going to do another one. We're going to do 140% of Medicare. I can tell you why they got it that number. Let's make it a second one. My point is, you can plug those set of assumptions into this interactive model and say, well, what is the implications of that? What is that implication of that member per month cost? And we're going to, and the commission is going to want a dynamic model like that.
I guess that's the part where the accuracy starts to come in for me. I think the expectation of accuracy with a model that you're describing, Roger, is probably a little bit higher than what it actually is going to produce. I mean, these are seismic changes that you're trying to measure the impact of a butterfly on.
Ben, you know, let me say one other thing up real quick. I couldn't agree with you more, but we got to build on something, right?
Yes.
No matter what we do, we're going to be wrong. And part of this is having a dynamic world we live in, is saying, oh my God, look at these implications of this. And who's ever going to be running this, we're going to have to make adjustments. But as you know better than I do, especially when we get into econometric forecasting, what is the confidence boundary around those and the error rates, right? They're huge. We don't talk about it, but we got to use those to make decisions. I'm with you completely on that. That's the world we live in. But the things I was talking about, you can do, right?
I mean, some of the stuff you're talking about, no, because it's an unknown. I mean, at some point, some of these changes are unknown as to how the population is going to react to a different structure. We can give an assumption, but the confidence interval is just going to be so wide that assumption is not worth making.
Well, if we don't do that, then we're not going to get anywhere. right?
Christine,
Yeah, I just wanted to sort of add to that. I mean, the CBO makes these kind of projections, like people have to make these projections and there are methods for doing it. And then you can look at, not even a confidence interval. You could say, what is the assumption? And what if we varied that assumption and put different bounds on it? But I mean, ultimately to make a policy, we're going to need some estimate, I think.
yeah. And an observation for me from having worked with both groups is that I think the commission is going to expect us to do most of the grappling with the technical issues and dynamic models and so forth. And they will
Yes.
want to be at a higher level, and they'll probably be very interested in trade-offs, which is the trade-off between premiums and point of service cost sharing, benefit design and point of service cost sharing, assumptions about populations and so forth. So that's just my, and I think that David had sort of a similar impression after meeting with them last time. And that's one of the reasons he came back with the models for us to start thinking about what models do we want to start using to think about this, because that'll be the expectation.
Yeah, and Ben, I appreciate your comments and sensitivities, but my impression is that what's important for the commission is what big requests of the legislature might need to be made in order to make some of these things happen. And it's not the precision of the request, it's even just the act of, in order to buy down cost sharing to zero, that's a multi-billion-dollar concept that somebody has to pay for. And even just seeing a rough illustration of that concept so that the commission can think through, gosh, is that something that they would then turn to the legislature and advocate for?
Mm-hmm. Yeah.
Pam, can I try one more? I promise I'll shut up. Okay, this is the one.
Go ahead.
Now follow up to Christine's and to Ben's. If folks are going to be asking FTAC to participate in this modeling, which would be great, a thought to consider, if we're going to be serious about this, is to structure a relationship that brings into the discussion, in this case, key legislative staff, so that when we're doing this modeling, they understand it and they understand the strengths and weaknesses, and it brings a degree of credibility to that would be essential in any ask of presentations or whatever with the legislature. And I want to use one example. You heard me say it many times before. It's the caseload forecast council that our state uses. That's done by the caseload forecast council. It has representatives from the House and Senate, both, R's and D's, the appropriations committee staff, policy staff, got OFM on it. It's got the affected agencies, they sort of medical system. So we were part of that. And we would go through these modeling processes and reach a consensus that this is, we're comfortable with these estimates. We're comfortable with these estimates to have them incorporated into the budget, which is what we do. And Ben, this is kind of back to your point is, those estimates get revised every quarter, and just like the revenue ones do. And it is the acknowledgement that we live in a very dynamic world that we're going to have to make adjustments, on an ongoing basis.
Okay. David.
Yeah, I had one last thought about tying it back to the charge to evaluate the whole Washington proposal. Half of whole Washington's proposal is a tax and financing plan, where the first half is a healthcare market structure plan, the second half is a financing and tax plan. And what I don't think we've gotten to is, what would we be asking the legislature to spend new tax revenue on? So I think the folks at Washington, they presented a proposal that we said, well, that doesn't line up with the barriers that we've come in contact with. And so I think, in my mind, where this ties all together is we're trying to figure out what is a structure that would make sense to present to the commission that may or may not need additional financing. So then the commission can fully understand their ultimate critique or commentary on the whole Washington proposal.
Mhm. Okay. I wanted to just, I'm not sure where we are in terms of time management, but I wanted to see if Ian or Eddie wanted to add anything to the conversation.
I like the slide, this is Eddie, the phase one that kind of gave it the bracketed approach of where we're moving towards from the eligibility, cost estimates and financing, and then going through what David's slides were, and then listening to Roger's comments. Are we trying to get our information to submit to Milliman to do the cost estimates? And do we need, I guess, to work on that so that Ben has what he needs to, I guess, give us some type of model that allows us to have a further deep discussion?
I don't think we're that far along from this group, I would say, for several reasons. But I think that I would think primarily is, do we want to give any feedback back to the commission about anything they might have that we think they overlooked, or how we want them to look at cost sharing or the trade-offs in adding benefits and uninsured populations and what that might do to cost, or anything we might want to say to them about cost sharing. We're a little bit all over the place in this conversation, but I think that's more our task right now, is back to the Universal Healthcare Commission rather than feedback to actuaries. And I think Ben agrees with me. Yeah. Ian.
Yeah, just really appreciate the presentation. I think I'm just trying to soak it all in right now. This is kind of outside my expertise. So no questions or follow-up right now, but really appreciate walking through this.
Okay, thank you. Liz, I'm gonna call on you for how we
Sure.
might close this out.
Sure. I think that
lively conversation.
Sure. I mean, I think, and I need Roger to help me here, but basically the question on the table from the commission in April was, these are I think it's to what you were describing, Roger. We're talking about modeling out initially at least how much do each of these benefit packages cost. And it was EHB, HEB-SEB, Medicaid absent long-term care, with dental vision. Those were the things that they said, we want to have a sense of how much these things cost. They just want to understand that part, not any of the other factors that we've talked about, no cost sharing at this point or anything, just how much does the benefit package itself cost? And I think the question for all of you is, does that make sense to you to just focus on that phase one first? And Roger, I heard you say there were 5 benefit packages. That was the only thing I just wanted to clarify and see if there was anything different.
Well, I do think we want them to look at cost sharing.
Yes.
I think that was in Roger's recommendation, and I think that's been consistent in discussion.
I do think it was, just to recap from the commission, I do think that they said that they wanted that in multiple levels. So yes.
Okay.
So Liz, let me go back to my one on the benefits. Maybe these are too finite, but there's the essential health benefits that are, let's say, in cascade, in the exchange, whatever one you want to grab there. When you look at, for the state of Washington, there are other, what they call essential health benefits that are optional, that can be provided in the individual and small group markets. And they're in the rules. I would say, put that one in there, because that is another option. In theory, that's another, what our state has said is the maximum in the individual and small group market. So that's kind of 2 that are built on the essential health benefits. There's SEB-PEB and Medicaid, as we say again, absent long-term care.
And Ben, please correct me if I'm wrong, but I think any modeling that is based off any silver or EHB plan would automatically include any mandated benefits because it's currently part of the calculations.
Yeah, EHBs, when you say mandated, you mean in addition to EHBs?
Yes.
Yep, the state benefits.
Yeah, the state mandated benefits.
Yep.
Does that answer your question, Roger?
Yeah, yeah, so one example, big dental, that's always the easy one, because everybody keeps it out. If you look at the essential health benefits in that thing, there's what's offered in exchange, and as a benefit design, as an option in the individual small market is dental, for example. I mean, they're listed, and I don't have mine in front of me at the moment.
I think you must mean pediatric dental.
No, it's dental.
As a separate offering on the exchange?
No. Yeah,
Medicaid.
If you look under, in our rules, state of Washington, essential health benefits, there's a list. And they say, you must, and those are kind of the essential ones, you know. And then you may, which are optional ones, like dental.
Oh, I see.
So.
But that's not a mandated benefit.
No, it's not, I'm sorry, but it says for our state, when we've gone forward and said our vision for the individual and small group market, here's what the option, the range of which they can offer benefits. Here's the scope of that benefits. And my guess, but this again is an actuarial one, my guess is it probably looks pretty damn close to what is in SEB-PEB, but you know, that's an analysis question. And beating this one to death, we may find there's such an overlap with this stuff. We say, well, why are we fragmenting this stuff? There's really only, you know, three buckets. But we made that decision based on some analysis that we would have to say to make that decision. And I do quite agree with Pam on cost sharing. And you, after you do the benefit, there's all this analysis around various types of cost sharing. And I agree with you wholeheartedly, Pam, that needs to be brought into the equation.
Yeah, and I think the commission asked for different analysis on the metal levels, which automatically includes cost sharing differentiation.
Right, that'll give them what they need.
Mm-hmm.
Mandy, I want to do a time check. Do we have till 4:30 today?
I'm just going to double check the agenda, Pam. Sorry about that. Yes, we do. Although there is a break scheduled at 3:55.
Okay, because I'm a little, you know, our next presentation is on cost sharing, and I know that's been a hot topic. So I kind of want to move us forward. I'm not sure we have a lot of clarity at this point.
I do know Peter has his hand raised from Milliman.
Oh, hi, Peter. Go ahead.
Sure. Sorry, very white. I was wondering if there were any populations that would be excluded out of that Medicaid bucket. And I'm specifically thinking about folks who might be dually eligible for Medicare and Medicaid, or otherwise disabled, and not sort of like the rest of the population they might be combined with on the commercial side.
I think for now we're excluding Medicare from the analysis.
Right. So how would those folks be enrolled? Those that are dually enrolled in Medicare and Medicaid, where would they get their coverage from?
So when you took long-term supports and services off the table, that's a Medicaid benefit. Most of the people that are getting that Medicaid benefit are the dual eligible population that Peter's talking about. So they would have Medicaid wrap services on the medical side, plus the long-term supports and services, as well as Medicare primary. So,
Peter, can I add one more to that complication? Because that same thing applies. When we've talked about SEB-PEB, we've sort of stayed aside from a discussion around retirees, Medicare retirees, because they're in the same situation. I mean, most retirees are dual eligibles, right? I mean, primary is Medicare, secondary is the state. But there are something like about 8,000 or 9,000 folks, just as a sidebar, who are retirees who aren't eligible for Medicare, and they're just in the regular risk pool for PEB and SEB. So I guess in a simple view of the world, if we are keeping out Medicare, your point's well taken. Well, we would, for now, at least in this analysis, it would exclude retirees and, as Ben was saying, the dual eligibles.
Okay.
Those are two different order of magnitudes, though, Roger. I think the Medicaid dual eligible is much bigger than any PEB-SEB type of issue.
Do you mean in terms of financial impact as
Yeah.
well as population size? Yeah, I agree. I know that Roger harkened back to the work that we did many, many years ago, and I think we just excluded those populations from our analysis. And I don't know what, but we haven't had an opportunity to pose a question or make a decision as a group this time.
I
I
could-
think in terms of the number of people, there's more retirees than there are cat needy aged blind.
Right. But I'm going to say, Peter, go ahead.
I was just, all I was, I guess, maybe to put the question more bluntly, I think a lot of the questions that were brought up during this presentation, the subsequent conversation, sort of our framework for the sorts of information that would be required to do the sort of analysis being requested. One of the key portions I felt more detail might be helpful around is the specific population, and really with respect to that non-commercial population that would be carved out or carved in order to do something else.
Okay. Liz, I'm going to call on you again on kind of how to proceed from here.
Okay, so it sounds like we're modeling, we're saying, agreeing with, we'll get recommending to the commission that they move forward on phase 1, looking at these 4 different packages that we just discussed with cost sharing and using the metal tier level for determining cost sharing options.
Liz, can I make a recommendation to that also? Because one of those, this isn't this cost sharing, I don't have my thing in front of me. But our state and most other states don't offer the platinum plan. That's the 90-10 one. And if we're doing these exercises, I would argue that that ought to be, you know, one of those steps in that. Because
Yep.
you know, it is a sequential step in terms of, you know, the cost sharing structure. So I'd offer to, when we're talking about the metals, it's the ones.
Yeah.
That's a great flag. I think Pam had that recommendation last time
Okay.
or something. I think you said
Yeah.
something about it.
Yeah, it comes pretty close to no cost sharing in the platinum plan. So I think it would be a nuance, a very limited cost sharing plan as opposed to zero cost sharing. So I guess it would give the commission that distinction. And then in terms of overall working on cost control simultaneously, I think we're mixed feelings in the group, but I think some people feel strongly we should do that. It may be that the next topic of conversation will help us with that, because it would be the presentation from Ross McCool from Healthcare Authority on the Healthcare Cost Transparency Board. So kind of, I'm looking at kind of, usually I kind of plow ahead, but on this one, because we didn't have specific recommendations on the table, I'm kind of looking to Mandy and Liz to say, should we go on to the next presentation or should we continue this discussion, kind of mindful of time?
I just think it would be great to just circle back with Ben and Peter and make sure that they have all the information that they need. So that would be my one thought, and recognizing that Ben and Peter are not quite, you know, that we have not tapped them as actuaries for this, but they're helping us out preliminarily. So, but they're kind enough to join us today, and I want to tap their subject matter expertise in creating potential models. And so, Ben and Peter, are there any unanswered questions or things out there that we should resolve in order to move towards an analysis?
No, I don't think so.
Perfect. Thank you.
Yeah. Thanks, Mandy, for that. I also would suggest we would come back at a future date with specific questions. If there, as I think as we move forward to getting the work done, things will arise in which we could be helpful. And I would want to offer the group to do that as that happens. Okay. Very lively discussion. I appreciate it. And I think
do you want to take the break now, Pam? Because I think the next agenda item is the board item. If I remember right, I'm just double checking the
healthcare cost. It is Mandy. Yeah. And I think this is when we get break is between the two.
Yes. So
and how many minutes do we get?
I think it's 5 on the agenda, but if folks need a little bit more, we have a little bit of extra, just a few minutes of extra spare time if you wanted to go to 10.
Okay, let's take 10.
All right then.
Hey, Mandy,
Yes, yes.
people are taking breaks. Just an FYI again, to you and Liz. If the Universal Healthcare Commission, for some reason, and I understand from the long run, would be interested in having a understanding of long-term, long-term benefits. Okay. There is a way to get at that. Milliman doesn't have that data, but RDA does, research data analysis, and they can put together, and nothing's free, but a nice description of those benefits, who gets them, and expenditures for each of those benefits.
Sorry, can I recapture that, Roger, and state that back to you to make sure that I understand?
Sure. Yes.
Okay. So what you're saying is there's an entity, and I don't know the entity. I just want to say that I'm clarifying that I don't know the entity, but so RDA is an entity, and they capture the distinction of benefits, design differences between the different plans. Is that what you're saying?
Yeah.
Okay, see, I was wondering if I was
DSHS is the RDA entity, right, Roger?
Oh, thank you. Well, then I do know.
Mandy, within DSHS is Research and Data Analysis Division. David Mancuso.
Okay.
David Maker. Oh, yeah.
What was that?
David Mancuso.
Oh yeah, David Mancuso. He's on the board, or he's on an advisory committee to the board. Mhm.
So what RDA can do,
Mhm.
it's informative. It's not, but they go through a great exercise to lay out the whole array, might drive us nuts, of long-term benefits, long-term care benefits for the elderly, disabled, and persons with mental health, etc. That whole array of benefits. They have utilization, so they have descriptions of it, they have utilization data, they can, cost per member information, or just total expenditures in each of those categories. Like the easy one is skilled nursing facilities. That's kind of an easy no-brainer for the Medicaid program. And why, in my own view, I think it would be kind of useful, not for our media exercise, but for the commission, is to say, when we're talking about long-term care, because it always kind of comes up, right?
Mhm.
What do we mean by that? Right? Well, here's what we mean by it. Here's the broadest benefit design that exists in our state for long-term care. Here's what that thing kind of looks like.
Yeah, and right now we're gonna try collecting those costs for the purposes of the cost board. So,
Not gonna- yeah,
sure.
so, not gonna-
Huh?
For long-term care benefits? Really?
It's required to. It's part of the cost analysis under the statute.
Well, go to David. You're
Well,
talking
good thing
about-
we have some connections with David.
Yeah.
Yeah, so we're beginning those conversations with DSHS, so this is definitely an in that we can ask about.
And in the context for us, it would be solely as an informative piece for the
Mhm.
commission in these discussions, because for the Medicaid program, I know we're gonna do this, we're gonna have to cut it somewhere. And there's ways of doing it and say, here's outside of this whole system. It's over here, life of its own. We're not gonna eliminate any of the benefits for those folks, but when we're talking about a uniform system, here's what's in from the Medicaid programs. That's why that exercise is kind of good to go through.
Right.
It gets a
Well,
little,
you mean Roger, to kind of say, looking at RDA data, these are the things that people who use long-term care, these are the most highest, the services that are in the highest demand. And thinking, if we wanted to create some type of benefit package, these are the services that people need the most. Okay, I get it, totally get it.
Or maybe greater understanding of the types of services that
Yeah.
are available there so that you can evaluate the benefit and against cost of those.
so a great example briefly is behavioral health. That's a hot topic for all of us, right? And we're there. So in behavioral health, there's two aspects I think of. One is there's a whole series of community support services, including residential support services. I mean, there's a litany of stuff. In my mind, that's going to be it's gonna be tricky. We're gonna have to chop that at some place and say, we're talking about a mental health benefit here, and we're gonna put in this some other arbitrary long-term care bucket for behavioral health folks, these sell. And here's what that kind of looks like. I'll give you an example. In fact, you folks contract with the Mayor Group to do something called, what is it, Foundation for Community Support? No.
Foundational community supports. Yeah, the supported housing and the supported employment.
Yep, supportive
Yeah.
employment, supportive housing. And actually, that one we contract with the Mayor Group to do, or I say kids, you folks do. Well, that's, that's a great benefit, but that's not gonna be part of, we're talking about a mental health benefit. That's not gonna be part of what's in the, the benefit design we're talking about. But I'm saying with the actuaries, I mean, when you get to the nitty gritty of this, there's ways that they can, and sitting down with everybody, chop those and put them in different buckets, right? And it's like, you may do all that minutia. But I think it would be really helpful to folks. I don't know if people have ever seen that data. I mean, anywhere. I mean, all that stuff. It would be quite an educational piece.
I agree. There's value in that data.
Sorry.
All right, I'm gonna run to the bathroom myself.
Thank you. Hi, Liz. Where are you?
Thank you, Roger.
I'm in Seattle in my basement.
Okay.
I should come see you sometime when I'm down in Olympia.
I'd love to do that. It'd be fun.
Yes. Yes.
Mm.
Well, I need to email. I'll email you.
Okay.
I'm coming down there a little bit more now, so would love to see you.
Here's a personal one. Hopefully, like today is an example. I've been talking too much, but like
You love
Okay.
this stuff. The Medicaid nerds conversation. It's fine. So it's all good. I'm gonna run to the restroom. I'll be right back.
FTAC.
Pam, while you're gone, I apologize to everybody.
When did that happen, Roger? Was I off screen?
I'm gonna unmute myself. I was gonna say, Roger, that's not good use of a break. We don't get enough breaks.
True that.
Okay, it looks like Ian is back, Eddie is back, Ross is here. I'd like to get started. Is that okay with you, Mandy?
That sounds great.
Okay,
I think
Ross.
you- Oh, is it Ross first? Sorry.
Yeah, I'm pretty sure that's right. Yes. So, Ross, we haven't met before, but I'm really appreciate having you here. And I can tell you this is a group that is very eager to hear about the Washington Healthcare Cost Transparency Board. So I'd like to just go ahead and let you get started. And I'm hoping we have a little time for discussion at the end.
Sounds good to me. I'll be covering the first 14 or so slides, and then I think HMA is going to cover some of the policy next steps after all that.
Okay. All right,
and then
great.
we'll answer a bunch of questions.
Okay, great. Thank you.
So to jump into it, I'm going to try and do a little bit of level setting from the previous conversation, because there's a lot of information about that, and I don't want people getting these two things mixed up. They're both very, very detailed. So for the cost growth benchmark, it's more of a monitoring system where we're looking at the expenditures in the state, and we're trying to set a target or a benchmark to slow the growth. Just having something set there, so that it's something kind of aimed for that we're looking for. For reference, Massachusetts started their benchmark around 10 years ago and saved millions of dollars simply by setting a benchmark. They didn't have to impose a whole lot of, I don't think they even did any fines in the first several years of it existing. So they did a great slowing the growth of healthcare expenditures in the state, saving millions of dollars just by setting it. So for Washington, what does our benchmark look like? Well, we adjusted our benchmark to be related to what people are experiencing in the state. So it's a hybrid of median wage and potential gross state product. And you can see on the table on the right that for the growth from 21 to 22, we're looking at a 3.2% benchmark. And then over a course of 5 years, we're slowly lowering that benchmark to 2.8%. And a lot of this data we're getting is expenditure data that we're asking payers to submit. We have carriers included in there because that's the majority that we're getting, but we're also getting spending from Medicare and Medicaid fee-for-service, as well as some other categories that we'll talk about later. And the real benefit of this is that we're getting not only claims-based spending, but also non-claims-based spending. Next slide, please. This chart just shows where we are in our yearly cycles. We are trying to, well, we have wrapped up the data, the analysis that we got from the data for 2017 to 2019. We are about to start collecting data for 2020 to 21. That's starting next week. We are getting all of our ducks in a row as best we can, but that is a huge lift. But this incoming data will actually be used to analyze the growth of expenditures in the state and actually hold people responsible, or not responsible, but hold people to that benchmark of 3.2%. Next slide, please. So what exactly are we measuring? So I talked about claims-based spending and non-claims-based spending. This slide goes into just a little bit more detail. We have a thing called total medical expense that we're looking at. And so this is payments that on providers' claims for reimbursement on the cost of healthcare provided, as well as all other payments not included on providers' claims. So this would be claims-based spending and non-claims-based spending. And then we also have the cost sharing. So this cost sharing is where we get the is why we're using the allowed amount, so we can get all three of this types of spending together. The fourth item on this list, the net cost of private health insurance. This is data that we get from either the OIC using supplemental healthcare exhibits or MRL reports from CMS, where we look at the total amount of premiums that a carrier has and look at how much healthcare spending they had taken out of their premiums, and that surplus is what net cost of private health insurance. So that's essentially what people are paying, or the premiums that are being paid beyond being spent on healthcare. And all those together are total healthcare expenditures, or THCE. Roger, I see your hand is up.
This, two questions. One, this is not just hospital based, this is all expenditures.
All
Number one.
expenditures, yes.
And then the last one, you mentioned about getting information from Medicare from their fee for service. Are you able to access Medicare Advantage
So
data?
the Medicare Advantage data comes from the carriers that are servicing the plans.
Thank you.
Welcome. Next slide, please. So this slide is looking more at kind of the 3 steps we're using. Like I said, the benchmark is a monitoring system. And so we have 3 different levels that we are monitoring to try and see where spending is occurring in the state, so we can try and identify where areas are needed for additional investigation or analysis. So the higher level, the state level, we're looking at aggregate spending on a per member per year basis, and we're looking at total healthcare expenditure. So remembering back to the previous slide, that's claims, non-claims, plus the net cost of private health insurance, basically the difference between premiums and healthcare spending. The middle step is that we're looking at markets. So Medicare, Medicaid, commercial. We're looking to see how those markets are growing and what areas they're growing, so that we can see if there's differences between how does Medicare look versus the rest of the state, or how does commercial look compared to the rest of the state. And then we have in the box future reporting, which is what I mentioned about actually benchmarking carriers and providers. This will be looking at per member spending. There's a little bit more information there. I don't want to get too much into it. The main reason we're doing some additional, we'll say truncation and age sex adjustment is to help make sure that a few high cost outliers don't push a particular provider or carrier over the benchmark target that we have. So that's just there to make sure that there is enough, make sure that there's nothing that's going to, a few high cost outliers are going to drive people over. I think I said the same thing twice, but that's the thing. Next slide, please. So just for a few highlights, we'll get into some more details in just a minute, but just the highlights for right now. In 2019, the total healthcare expenditure in the state was $48 billion. One of the largest service areas that we saw was hospital outpatient, which are significantly growing. Looking at the growth from 2017 to 2019, we saw that statewide total healthcare expenditures increased in 2018 by 7%, and in 2019, almost 6%. Some of the more market-based highlights we saw was that Medicare per member per year appears to have slower growth than Medicaid or commercial, and Medicaid seems to be growing faster than other markets, but still has a lower per member per year spending than commercial or Medicare. Next slide, please. All right, and then this slide is showing those categories added together. So you can see in 2017, commercial being at the bottom has about 16 billion spending, excuse me. Purple is Medicare at about 14. Medicaid is about 7.5. The dark blue is net cost of private health insurance. And then the light green at the very top is other. And so I'll talk about the other now. That's spending for things such as Labor and Industry, Department of Corrections, and Veteran Affairs. And so this is just total spending. You see in the top right-hand corner how much all that spending added up together. Roger, you have your hand up.
I think you've answered the question because I was surprised when I heard about Medicaid when I was going there. But you're talking about total expenditures, not per capita. Is that correct?
Could you expand on your question a little bit? Because this is the total, what we're looking at right now is total healthcare expenditures in those markets.
You made a statement that Medicaid was growing, at one of the faster rates, and Medicaid is caseload sensitive, so you can see it jump in Medicaid expenditures, but it's not driven by underlying per capita costs. It's caseload. So
we'll get to that in just a moment when we start talking about expenditures versus per member per year expenditures.
Sorry.
It's okay. We're getting to it. Next slide, please. Okay, so now we are getting into the per member per year expenditures. So how much money are we spending on each person in that year? So this is a little bit better measure than just total overall spending, because we want to take into account how much spending is done on a per person level. So kind of the thing to think about is if you double the number of members you cover, of course your healthcare spending is going to go up, but you want the amount that you spend per person to stay relatively the same. So we want to take into account the people that are being covered and that change over the years to see how the total healthcare expenditure is changing based on that. And this is the total healthcare expenditure per member per year for the estate. And it is going up by about 7% and about 6%. I think I mentioned that in the highlights, but here's the graph showing that. And then I think we break that down into markets a little bit later. Next slide, please. Okay, so this is Medicaid overall spending. And we've gone back to just overall spending just to kind of see what those absolute values are. And for Medicaid, we're seeing 11% increase, 11.5% increase, and a 10% increase over the time period. I'm going to go ahead and go to the next slide here, because I just want to give like a high level for this. Next slide, please. So this is the commercial spending, and that is and that absolute value is increased by about 5% from 18 to 19. And next slide, please. Oh, I think we missed a Medicare slide somewhere in between there, or not Medicare. Yeah, Medicare, absolutely. Perfect. Thank you. For Medicare, the absolute value increased by about 6 to 7%. And then we'll go to the slide we were just at. Thank you. So now this is the per member per year for each year, and the percentages over them are that increase. So looking back to Roger's question, the Medicare per member per year grew by about 3% when you factor in the total number of members from the data we received. Medicaid increased by about 12% over the years, even though it's still a lower per member per year value. And then for commercial, that increased by about 4% over the years. Yes, next slide, please. Okay, this is going to be a very complicated, but I'm just doing an overview just to kind of show some differences. There are higher resolution charts in the appendix to this that we can go over during the questions, or you can explore on your after the meeting. But these are bubble charts that we have. We're going to focus on the top left one right now, the state claims per member per year growth. Oh, that says state claims. That should also include non-claims because we do have that bubble there. But anyway, just to kind of describe this chart, because it is trying to tell us 3 different things at the same time. The further right you go on the x-axis, the more per member per year spending is done during the latter year. The higher up you go, the more that particular service category has increased since the last year. However, the important thing to look at are the size of the bubbles, and because the size of the bubbles represent the contribution to overall growth since the previous year. So for example, if one service category went from $10 per member per year to $20 per member per year, that's a 100% increase. That sounds like a huge increase. But if you compare it to something that's $1,000 per member per year and it went up to $1,100 per member per year, that's $100. That's way more than the $10, but only showing up as like a 10% increase. So the important thing here is that the larger the bubble, the more the increase in spending contributed to the overall growth. I want to pause here to make sure that that everybody can work through that through their mind, ask any questions they have about that, because that's a very important part of what this is showing. And Roger, your hand is up.
Sorry, I'm looking at overall and this Medicaid, but Laura, can you give an example of non-claims? What's in that?
So non-claims is a large category that we've broken out further in the actual data we collect, but we just left it as one giant bubble, so it's a little bit more clear. So non-claims would be things such as capitation and bundle payments, population health spending, as well as things like, oh, I had that category and then I completely forgot it. There's also things such as recoveries. Oh, performance incentives. Forgot that was the category I was trying to remember. Performance incentives. And then there's also a bucket of claims, non-claims other, where if there's other non-claims, but they don't really know where to bucket it, it goes into the other category.
So Oscar, real quick again, I'm sorry to see this. So I'm looking at Medicaid, back my usual, I see 9 claims. It's a big amount there. So is that's where Healthy Options is for Apple Health? That's where your managed care pieces are.
So skipping ahead a little bit.
Sorry.
But we'll get to that in just a moment. That's okay. David, your hand is up.
Yeah, thanks, Ross. Just a small detail. I appreciate all your analysis. First of all, the state moved to integrated managed care for Medicaid, so behavioral health expense became a Medicaid expense. Right around 2019 is when most of the counties converted. So I'm just speculating that might be part of the reason for the Medicaid growth.
Okay, well, we'll go ahead and talk about that now. So what we're trying to show with these charts is not only where spending is, but how spending differs among markets. So we have this kind of bird's eye view of what's happening, and we drill down a little bit further. Everybody, I've got 2 questions or comments about the Medicaid non-claims. And yes, you're both right. That's when IMC was being phased in and when that level of expenditure greatly increased. And so we can definitely see non-claims is the leading cause of growth for Medicaid during that time period. That's also when we backtrack to the per member per year spending and that increase, we can see that non-claim spending is a major factor in that. But we can also see that in commercial, non-claims is not one of the major contributors to that. What the major contributor for commercial is that hospital outpatient. Even though hospital outpatient in the state overall is also a large contributing member of spending growth in the state, it seems to be mostly occurring in the commercial market. And then looking at Medicare, we have claims other. That seems to be the largest contributor to growth. Claims other includes things such as durable medical equipment, freestanding diagnostic facilities, different things like that. So it is a large bucket of just other categories that is expanding. So what we can do with this information is, okay, so this is affecting these different service categories are affecting different markets in different ways. So then we can do what we call a cost driver analysis to really dig into what is driving those increases. But like I said, the benchmark is a monitoring system first. And so we need to have this higher level detail so we can figure out where we need to investigate and then later determine how to investigate that. But we're still at the monitoring phase for the benchmark. Any questions before I hand it over to HMA, I think Liz? Oh, a couple of questions. Excellent. I think Eddie, I saw your hand up first.
Yeah. I was, the non-claims title is a tough one to, it's managed care premiums. But managed care premiums, if they were to be broken up into those individual pieces, which you can't do, then would allow it to compare itself more to the commercial quadrant. Was what I was kind of feeling. Is that what really non-claims is? It's what Roger had said as well. It's PMPM.
So non-claims, for what we're looking at these charts, are several different categories. So it's not just the capitation and bundle payments, which I think is what you're referring to.
Yeah, I mean, it has to be a huge part of it.
But it's also looking at performance incentives, is also looking at investments in population health or infrastructure. There's also recoveries, which is a net negative, essentially on spending because they're recouping money. So there's a lot of things that go into it.
Well, on the
But we could,
Medicaid side, so much of it's managed care, and all what's in the fee for service is either carve out or just pure fee for service. So that's what is that what I'm seeing there because of the difference? I mean, I know the bubble represents the growth between 18 and 19, but just because the blue bubble is so large, I would say a majority of the dollars would be represented as a PMPM.
I'm not understanding your question.
When it says non-claims, that is the capitation for the managed care component of Medicaid.
Not
Right.
solely.
Okay,
So I can't say, yes, that is solely the capitation rate for Medicaid because it includes several other things.
so for other things as well. So the back end data for this, is this the APCD?
No, this is, I think this was mentioned on slide 2, where we're asking not carriers, we're asking payers, which includes carriers, but we're also getting data from LNI, DOC, VA, as well as CMS for the fee for service side.
Yeah, it was interesting because those are some of the same sources that are in the APCD, but you have your own survey that you conduct to bring and aggregate this data together.
Yes, and we have to do that because the APCD does not have non-claims data in it. And the
Okay,
APCD data does not have self-insured data other than PEBSEP.
okay, thank you.
Roger.
Thank you. Just a quick one. Under commercial, that would include 7 PEB?
Yes.
Thank you.
Absolutely. All right. Any other questions before I hand it off to HMA for the next couple of slides? Oh, all right. Thank you.
I
Thank
have
you,
one more
Ross.
question, sorry.
Oh.
And that was just, when you were looking at the bubbles with the Medicaid, is that the total amount of federal and state, or is it just the state amount when you're doing your analysis?
Oh, for Medicaid, that is Medicaid. There's a list of exclusions and caveats in the appendix, so I would encourage you to look over that.
Okay,
But for the Medicaid, that is spending reported by the carriers that manage
okay, so that's
MA,
100%. Okay,
as well as the fee for service that we get, or the Medicaid fee for service reported by HCA. There's also a large bubble in claims other from Medicaid fee for service, because they don't classify very well into one of the other categories of non-claims.
thank you.
Okay.
Great. Thank you so much, Ross. We can go to the next slide. I think Ross mentioned at the beginning of his presentation that really the cost board over the beginning of their work has really been focused on taking in the data and making sense of it and trying to really get their arms around what's going on, what are the drivers of cost. Over the last few months, though, the cost board has started to look at, okay, we see where the costs are. We're starting to really understand the problem more and more. And in February had a conversation about, okay, what do we want to do about this? What do we think some of the policy options that might be available to address some of these, address these issues? So this table really shows, we HMA with HCA staff presented several policy options to them based on a number of things, but asked the board to rank the policies they wanted to spend more time on over the course of the next year, really digging in deeper to understand, like, could this actually help this problem? And as a result, exercise, they are spending the course of 2024 looking at these policies that are in bold here, limiting facility fees. The ones that have an X on the end, limiting facility fees. They're looking at restricting anti-competitive clauses, mergers and acquisitions and private equity, purchasing of healthcare providers. And if we go to the next slide. Next slide. Provider rate setting and price growth gaps. And you'll see there's a column actually that talks a little bit about what's happening with the OIC. They're also doing a lot of analysis and research focused on policies to address healthcare costs. So we just wanted to share this with you so that you could understand that there's going to be additional work going on both at the cost board and with the Office of the Insurance Commissioner to really look at what the potential impact of adopting some of these policies might be. And so to kind of go back to our earlier conversation, I was sort of jumping ahead and saying, well, do we want to think about how something like this, if it's part of the design of the universal system at the outset, or if, for example, because I think some of these are being considered as possible solutions for the existing healthcare markets, what would the impact of that be on the long-term cost of the universal system? So just wanted to make sure you were aware of that, and ask any questions about, if you have any questions about these policies that are being looked at, what would you like the relationship to be in terms of hearing about this? Any suggestions or things that you want to make sure what the FTAC or commission should be thinking about if it's not in one of these buckets. So, Roger. You did. I feel like I need to have a thing, Roger, that unmutes you from my end. It's okay.
Great presentation. Two things come to mind. One is, we had an earlier conversation, cut to chase here, Roger. Coordination between the Healthcare Cost Transparency Board and the Commission. And it's more than just until. Here's why I say that. We've had conversations, today about issues around cost containment, right? Cost strategies. And if Bob was here, he'd raise hell because global budgets aren't on the list yet. And I say that realistically and facetiously. But the point is, we need to work intricately together. If the commission is going to be asking us to look at cost containment options, I can tell you, we in FTAC have a fairly limited amount of resources, right? Mm-hmm. And in theory, this is the charge of the Healthcare Cost Transparency Board.
Are others frozen? Or is that just Roger?
Just Roger, I think.
No. Okay, he'll probably come back in a minute. I should clarify, even though to just say that global budgets are on here, they're being looked at by the Office of the Insurance Commissioner.
Yeah, I saw that.
And
that.
Same with reference-based pricing. So, but I think Oh, Roger, you're cutting in and out.
It's okay. Roger, it might help if you turn off your camera because we're all having trouble hearing.
I can turn off my camera too to save your bandwidth.
Oh, you're fine, Liz. We can hear you.
I never know how it affects everybody. So
yeah, I think we might have lost Roger. He'll be back, I hope. Can I ask a question, Liz, while we wait for him to come back? So I think that I would be really interested in linking to any assumptions that are being made about what these measures could drive, because that would link pretty closely with the overall benefit package. And I think that's, starts to create a framework for understanding, what the recommendation would be that we put forward. And I think that I'm very interested in the trade-offs between some of these items and things. Yeah, also how the commission's thinking of things sooner rather than later. I think they're probably taking a longer view, which I think can be really helpful. So that'd be good insight for us, because I have a feeling that our group would probably be more interested in front loading things so that you can create more affordable healthcare in the short run.
Right. And I think that's so Pam, what I hear you saying is you'd like to hear, as these evaluations or models are built, you want to hear what those assumptions are, because it could help inform the thinking of the
Right.
FTAC. Right.
Exactly. Well said.
For long term, for the design of the system, but also I think these are also things on the table that could be done absent of a universal system. So they could be done sooner.
Mhm.
I would imagine there would be some coordination between the commission and the board if the board makes recommendations related to these things, so that if the commission or FTAC was interested in supporting those recommendations, there would be an opportunity.
Right.
Did Roger come back?
I haven't seen him back.
Okay.
He might have inadvertently hung up when he turned off his camera. I still think he'll be back. Any comments from others, David or Ian or Christine?
Pam, just seeing the list is great. Like, it's great the Transparency Board is working through these things. I'm guessing if I was sitting on the commission, I still might want some help to understand, okay, how does the Transparency Board's work fit into what we're doing?
Mm-hmm.
So that's my only reaction so far.
Yeah.
Right. So really just trying to articulate the relationship a little bit more between the work they're doing and how it could eventually impact their recommendations about a future system.
Mm-hmm.
Like, why does it matter?
And I think it sort of naturally and nicely fits in with the discussion we're having, because ultimately, I think whatever actuarial study makes its way to the commission is going to have price tags associated with it, and it's going to naturally lead to the question of how do you reduce that price tag.
Right, exactly. And I think the good news is that, well, I don't know, good news to some, bad news to others, but my understanding of the work that's happening in OIC and the cost board is that they're not waiting for a universal system. They're looking at these things as something that they can do sooner rather than later, because they're concerned about healthcare costs for people. So
yeah, and I think that's Bob's point, is
yes,
whether it's global budgets or whatever, that's something that it can affect the self-insured and maybe even the Medicare market, even if a system isn't looking at pulling those sectors into
that's right,
an evolution of the system.
Yeah. Liz, is in terms of staying in communication as we go along, is it best just to work through you, or to have,
I think Mandy and Jane on the UHC. So I think we can just be very intentional about making sure that the information that is coming out from there is brought over here.
That would be great. I think that'd be
And
appreciated.
there are members like Jane who serve on both.
Mhm.
So there is a sort of cross-representation.
That's great. Okay, anything else? Very quiet. Okay. I think we're ready to wrap up then, Liz, unless you have anything else you want to say in terms of closing. Okay. I'll work with Liz and Mandy to think about what we bring forward to the Universal Healthcare Commission from this discussion. It was a really, as usual, very lively discussion. There were a lot of things raised about the benefit package, cost sharing, cost saving measures, and may shoot that around to the group to check back with you, just because we didn't, usually we have a typical, like, we draw to a conclusion or a recommendation. We didn't have that kind of structure this time. So just to make sure we are more or less on the same page, or if we're not, we'll bring it forward to a future meeting. I really appreciate people's time. Really want to thank our Milliman representatives, Ben and Peter and others for joining us today. I think that was really helpful. Special thanks to David, who put a huge amount of work into that presentation. And I think we will be using that in the future going forward. Did you want to say something, Ben? Okay, you have an ask to unmute on your screen. I have no idea why. So, all right, I think we're good. Thanks very much, everyone, and look forward to seeing you next time.
Thanks, Pam.
Thank you,
Thanks,
everyone.
everyone.
Thank you.
Bye.
Thank you.
Have a great day.
Okay, it's just you and me.